Good afternoon and welcome to this afternoon's clinical presentation. Uh, Going to the gym is now currently an in thing and many youngsters are into it for various reasons. So it has its problems. So to highlight this issue this afternoon, the department will be presenting a couple of cases to show what things can go wrong. So initial presentation of the cases will be done our senior student Dr. Kiran, followed by a brief discussion with Dr. Kiran.
Thank you, sir. Good afternoon, respected faculty members and my colleagues. I'm interested in the initial part of today's PCL. The title of the case was Hidden in the Body, Renal Program Excessive Body. So here we have an index case, Mr. He's a 24-year-old male, resident of Delhi. He's a graduate degree holder. He's a professional bodybuilder and a gym trainer. Patient himself has given a history and the history is there. And here on the right, we see the patient's image, which was obtained from his online training program for bodybuilding. So he had presented to our OPD on 27th of February 2025 with history of proteinuria since the last 1 month and elevated BP recordings of over 160 over 100. So he had a serum creatinine of 7.1 during routine evaluation for fever in January 2025 this year. So he was initiated on steroids at a dose of around 0.5 mg per kg from an outside hospital which he had initially considered. And this was done empirically without any renal biopsy, and the steroids were initiated in the second week of February. So coming to the negative history, the patient was not enzymatically denied any history of oliguria, no hematuria, no dysuria, and there was no history of any renal stone. He denies intake of any CAM, analysis or blood transfusions, no ocular or auditory symptoms or manifestations of connective tissue disease or any skin rash. There were no lower respiratory tract symptoms, epistaxis, nasal flushing or hemolysis. The family history was negative for chronic kidney disease and there was no history of recurrent UTI in his child. So coming to the examination, the patient was conscious according to time, place, and person at the time of exam. He was muscular with a heavy build physique. His height was 180 centimeters. He weighed 108 kilos, and his BMI was 33.5 kilograms per meter square. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. A urine multi-stick examination was done in OPD which showed 4 plus for protein and with no blood detected. So coming to the vital examination, his BP was the tune of 164 over 90 with a pulse rate of 78, normal volume and regular rhythm with a respiratory rate of 14 per minute. Fundus examination revealed no evidence of hypertensive retinopathy and his systemic examination were within normal limits. So coming to the initial set of investigations, as we had already discussed, we had an initial presenting reaction of 7.1 in Jan 2025 when he was undergoing evaluation for fever. Post that, the patient had presented to our OPD on 27th of February 2025 and the initial set of investigations that we have from May showed a creatinine value of 5.35, hemoglobin of 13.8. He had 3 plus proteinuria on his urine routines with 2.3 grams of protein in the spot urine PCR and 1.7 grams on grams of alanine excretion. So we had around roughly 2 times ALT elevation from his baseline, although his albumin was preserved. So coming to the additional set of investigations, we can see that his vitamin D3 levels were in the normal range. There was slight elevation, although less than twice the elevation of his intact PTH levels. Viral markers were negative. He had an A1C value of 5.4. CK-NAC levels were around 800 to around 2 to 3 times elevation. T3, C4 levels were normal, ANA was negative, anti-DHDNA was negative, ANCA was negative, and the ultrasound KUB was done, which showed bilateral normal sized kidney although with raised cortical echo. We underwent a 2D echo, which showed evidence of moderate concentric LVH, with the ECG showing evidence of left axis deviation and LVH. Right? And his renal artery Doppler was negative for any stenosis. So coming to the personal history, so he dug deep into history and he committed that he had self-prescribed and he was self-injecting the following drugs. So he was on testosterone enanthate 150 milligram daily twice per week, Methadone, Nanatate, 150 milligram IM twice per week, Prostanolone, Propionate at 150 milligram IM twice per week. He was also taking growth hormone 2 international units daily, 6 days a week. So he was also on these dietary supplements. He was on whey protein 40 grams per day, creatine monophosphate a total dose of 10 grams per day, 750 grams of chicken meat, and 18 egg whites per day. So his total calculated protein intake was to the tune of around 3.2 grams per kg per day. So this was the our working diagnosis. So we have a young male, 24-year-old, no prior comorbidities, prime of the young. So he has suddenly presented with a creatinine of 7.1, and from his investigations, we don't really find any soft markers for CKD, like he was not anemic, his IP test was not significantly elevated, his renal size was preserved. So we wanted to give him the benefit of doubt, and we checked a diagnosis of acute kidney disease with some nephrotic range proteinuria. And our pathological differentials were first one was IgA nephropathy, because IgA nephropathy being the most common glomerulonephritis in this particular age group. And the second one was drug induced, could be tubular interstitial nephritis or a secondary FSGS. So the patient was admitted, and he received 2 sessions of hemodialysis, and his BP was optimized. And he undergone a percutaneous ultrasonography treatment. So I now invite my pathology counterpart, Dr. Srivasan, to discuss.
Good afternoon, everyone. So we received a renal biopsy which comprised of one core and it had cortex only, a maximum of 12 glomeruli were seen, and none of the globes showed any endocap or mesangial hypercellularity. So, but 8 out of those 12 glomeruli showed global sclerosis. We can see here this globe is completely sclerosed. One globe shows segmental sclerosis, the part of the globe is sclerosed with podocyte hypoplasia, as we can see here. These podocytes are crowded. Inflammation was around 50 to 60%, and there was severe chronic inflammation in the interstitium. Artery showed mild endothelial hypoplasia, and the arterioles were unremarkable. The IF was performed for this case, and it was negative for IgA, IgG, kappa, lambda. IgM, C3, and C12 were also negative, but they showed peripheral and mesangial entrapment. So, a diagnosis of focal segmental glomerulosclerosis (NOS) was given. Further, the biopsy was also gone through electron microscopy, which showed one globe. And in this EM image, we can see that these are the upright foot processes, which are normal, and this part shows effaced foot processes. So it is different from here, and these are effaced foot processes with 40% of actin condensation. The GPM was normal child nominal architecture with a thickness of 226, which is normally within the normal range. There were no electron dense deposits and no evidence of any endothelial injury. So, final diagnosis of FSGS was given.
So now revisiting the diagnosis, after we have seen the biopsy findings, so this is final diagnosis of our next case. So he's currently CKD stage 4 with an EGFR of 17 ml per minute. Secondary FSGS with severe tubular interstitial chronicity with a score of 50 to 60%, due to a combination of anabolic androgen steroid intake and high protein diet that he was consuming and hypertension. So coming to the treatment part, so after the biopsy, we advise the patient to completely cease intake of high protein diet and its hormonal supplements. So he was initiated on RAS blockers with BB targets of less than 130/80 and to stop this heavy exercise workouts. So the coming to follow up after the renal biopsy, as we can see, patient had a creatinine of around 4.73 at the time of biopsy, and which has maintained more or less stable over the course of the next 6 months. So at the initial time of biopsy, he had 3 plus proteinuria. So post his cessation of workout and intake and supplements. So the proteinuria has significantly reduced over the course of the next 6 months, and the initial protein excretion of 2.4 grams has come down to 759 milligrams, over the course of next 6 months. So currently, the patient had a peak weight of 108 kilos at the time of fitness. So over the course of the next 6 months after stopping the supplements, it has reduced to 80 kilos. So as we have seen from the trace of the record, the proteinuria has reduced significantly. His creatinine and his BP has stabilized. Although we had started with the diagnosis of acute kidney disease, but in view of the significant IFTA and the significant cirrhosis of the biopsy, so the family and the patient, they have been counseled regarding the progressive nature of the disease and for a likely need for a renal transplant in the future. So this is the second case of the series. So Mr. B, 35-year-old male, is a resident of West Bengal in India. He is also a professional bodybuilder and gym trainer since the last 10 years. Patient himself has given the history. So coming to the chief complaints, he had exceptional shortness of breath along with headache and palpitations. So the onset was post his workout and he was been experiencing these symptoms since June of 2024. On evaluation, he was diagnosed with hypertension and that initial BP recordings were at around 200 over 130. So we had associated proteinuria also for the prior 2 months. So we visited our OPD in July of 2024. So similar to the previous patient, he did not have any edema, oliguria, hematuria, dysuria, renal stones, no ocular auditory symptoms. Did not have any stigmata of any other illness, no family history of CKD, retinal UTIs. And he was neither diabetic or hypertensive. So this person was also taking supplements comprising of whey protein, anabolic steroids, amino acids, and growth hormone. So he had a baseline creatinine of 1.4 in September 2023, which was not evaluated for it. So examination similar, well-built and heavy muscular physique, BP of 144/90, regular pulse, and BMI of 31.7 kilogram per meter square, and 4 plus proteinuria of the urine history. And there was no evidence of retinopathy of context. So this initial value of creatinine, as we have discussed, that was 1.4 in September 2023, which was not followed up with for almost a year. Next June, he starts having symptoms of shortness of breath, and that time he was found to be a hypertensive and his creatinine is already 2.42. So he comes to our OPD in July of 2024. At that time, his creatinine was around 2.56, 3 plus proteinuria was there on the urine routine, and around nephrotic range proteinuria around 3.7 grams. So we did the further investigation. C3, ANA, anti-DSDNA, and were all negative. He had a normal size kidney, although very steatotic, and evidence of LVH on his echo and ECG, and no evidence of renal disease. So as we did not have any clue on the final initial workup, so whether I then did a renal biopsy, so later on we discussing the findings.
So we received a renal biopsy, which was composed of 2 cores and predominantly composed of medulla, and only a very tiny part of cortex was included, and that had 5 total glomeruli. Out of those 5, 3 showed segmental sclerosis. We can see a part of the glomerulus sclerosed, and the other 2 were unremarkable. None of the glomeruli showed any global sclerosis or any endocap or mesangial hypercellularity. The tiny cortex included, because of that, we could not comment on the juvenile gestation chronicity. The arteries included showed mild fibromyalgia hypoplasia, and the arterioles, as demonstrated, showed granulomatosis. AIIMS were found and it is predominantly negative. IgA, IgG, M, kappa, lambda, C1q were all negative, and C3 showed peripheral entrapment. And EM could not be performed because the sending sections did not have any gloom in them. So a diagnosis of focal segmental glomerular sclerosis AIIMS was given.
This was our discussion of the case series here. Now I invite Dr. Renal to address the review.
Good afternoon, respected faculty members and dear colleagues. We'll go through the discussion. We'll discuss the pathophysiological mechanisms, how these supplements lead to renal injury, and we'll also go through some literature on the effects of these supplements. So, fitness supplements, they date back to the ancient times when the ancient Greeks, Egyptians, Romans, they used to take these mainly herbal preparations, and this is now evolutionized in the form of use of anabolic steroids by the fitness trainers and bodybuilders. So these sports supplements, they can be divided into two types: nutrition and non-nutrition supplements. The main nutrition supplements are creatine, vitamins, proteins, and various other amino acids and minerals. The non-nutrition supplements are anabolic steroids, growth hormones, and various other hormonal preparations. So the anabolic steroid family can be divided into three groups: DHT, testosterone, and androgen. So DHT is the one which involves 17 alpha hydroxylation and which leads to reduced first pass metabolism in the liver. And so all these compounds in the first column, they are all orally bioavailable. Rest of these compounds are mainly injectable. And the highlighted ones are the predominant used: stanozolol, boldenone, tranolone, and nandrolone. Coming to the multi-system effects of anabolic steroids. So the major organ systems involved are heart, where like electrical hypertrophy and reduction in ejection fraction occurs. Liver suffers from hepatotoxicity. Various effects on kidney will be discussing soon, and some cosmetic effects like hirsutism, acne. Also, there is hypothalamic pituitary axis suppression leading to hypogonadism and infertility. Coming to the renal effects of anabolic steroids. The main mechanisms by which they affect the kidneys are reduction in glomerular density, leading to hyperfiltration and kidney injury. They cause direct podocyte apoptosis, resulting in FSGS. Also, by the unknown mechanism, they cause hypercalcemia, leading to nephrocalcinosis and development of CKD. And by causing hepatotoxicity, they can cause bile acid nephropathy, which can further cause ATN and affect renal function. So this was a pioneer paper which drew attention of the general public towards long-term renal effects of long-term use of anabolic steroids. So it was a study published in CJASN in 2010 by Hurlitz, and they studied 10 bodybuilders who underwent renal biopsy for indications of proteinuria and deranged creatinine. So they found FSGS in 9 of these 10 biopsies. 3 were collapsing pattern and 4 were periannular pattern. More than about 7 bodybuilders had more than 40% IFTA on the biopsies. So what they did was they stopped anabolic steroids in these patients, and on follow-up 1 developed ESRD, 7 had stabilization of renal function, and one of the bodybuilders started consuming anabolic steroid again, and it was associated with a relapse in proteinuria and worsening of renal function. Further, we have another study of 2018 where 22 bodybuilders from Kuwait were studied, and they found the FSGS was a major lesion in 8 of these biopsies, followed by nephrosclerosis in 4 biopsies. And the mean duration of anabolic steroid exposure in this study was about 3 to 4 years. Another study from Iraq published in 2020, which was the observation study of 15 bodybuilders. So they found these bodybuilders reported consumption of protein powders in 86% of these population. 79% reported use of creatine. 26% reported anabolic steroid use, 5% were using growth hormone injections, and 2.6% were using high dose of veterinary grade vitamin D injections. And 5 of these patients had ATN on biopsy, 2 had ATN secondary to myoglobinuria, 2 had FSGS. It is worth noting that the FSGS patients had the maximum duration of exposure to steroids and maximum duration of training. It was about 10 plus years in both the FSGS cases. Next, we'll talk a little about growth hormone injections and how they affect the kidney. So they cause glomerulomegaly and increase kidney size. They also activate RAS. Further, they cause sodium and water retention, lead to fluid overload, and all these 3 insults together lead to renal injury. Next, we'll talk about high protein diets on kidney function. So high protein intake leads to glomerular hyperfiltration via causing efferent arterial dilation and efferent arterial constriction. And this hyperfiltration hypothesis was well explained by Sir Barry Brenner. And regarding if high protein diet is really injurious to kidney or not, while the evidence is poor quality till now, firstly because the definition of high protein diet throughout the literature has been inconsistent. Some studies state that more than 25% of the calories from diet
if obtained from proteins, constitutes high protein diet. And various other definitions have used the cutoff of protein intake of more than 1.5 gram per kg per day. Second dilemma is use of body weight relative protein intake versus absolute quantity of protein intake. As it has been hypothesized that absolute quantity of protein intake is more important in causing renal injury rather than the per kg weight related protein intake. Also, animal protein versus lactoprotein versus plant protein, all these three have different metabolic profiles and different effects on the renal injury. So, it has not been studied. And high protein intake has different effects on healthy population versus patients who have already compromised renal function. So, that also needs further studies. And no long-term study exists regarding the effect of protein on kidneys. However, as much as evidence exists, we can state that glomerular hyperhemodynamics is altered in the form of hyperfiltration, and patients who have already compromised kidneys, they will suffer from accelerated worsening of GFR. It can also lead to development of hypertension. It will cause most of the high protein diets are accompanied by low carbohydrate content, so it inevitably leads to ketosis, and ketosis further leads to diuresis, natriuresis, kaliuresis, and development of orthostatic hypotension. Also increases the risk of nephrolithiasis and adverse effects on bones. Do chronic nitrogen-rich diets really cause kidney overload? So, high protein diets will be one of the sources of nitrogen-rich diet. Secondly, these bodybuilders will consume high amount of creatine powders, which also contribute to the nitrogen load. So, there was a randomized controlled trial regarding whether creatine supplementation has an adverse effect on kidney function. So, they randomized patients in two groups. 12 patients were taking creatine and 14 were taking placebo. So this they took for a period of 3 months at a daily dose of 5 gram per day. And what they found is at the end of 3 months, there was no difference in albuminuria and no difference in serum creatinine in both these groups. However, it was a very short-term study and there was no long-term follow-up. There exists one caution in people who are taking high protein and creatine supplements that these will lead to diuresis and can cause later hypovolemia, dehydration, and trigger AKI, particularly in hot climates. Also, there have been a few case reports of development of AIIMS following creatinine use. Next, we'll talk about vitamin A, D, and E injections and their renal effects. So, vitamin D injections readily intramuscularly will increase the amount of 25 hydroxyvitamin D. Also, there will be a granular formation inside the muscles, which will express 1-alpha hydroxylase and increase the amount of active vitamin D available. All these things will cause hypercalcemia, and hypercalcemia further lead to hypercalciuria will cause increased incidence of nephrocalcinosis and nephrolithiasis. There was a meta-analysis on the nutrition and non-nutrition strategies and their impact on kidney function. So they included 13 studies. This is a summary of these 13 studies. They found that bodybuilders consuming 2 to 5 grams per kg per day of protein were suffering from increased renal decline and postulated by increased hyperfiltration. Creatine has been hypothesized to be safe in this study. Anabolic steroid use are definitely harmful because they increase incidence of AKI, increase FSGS, and increase severity of kidney injury. Vitamin A D supplementation also were postulated to cause hypercalcemia, leading to increased AKI and CKD. And NSAID and diuretics are two other factors which have not been specified in these studies, which can be important complicating factors in worsening renal injury in these population. Also, there is one caveat in these patients since they have a very high muscle mass and high protein content in the diet. So, serum creatinine estimation would not be a reliable marker of kidney function, and cystatin C has been found to be a better marker in this population. So, we should definitely advise them to stop using anabolic steroids once we recognize evidence of renal injury. To reduce hyperfiltration injury, they should be considered RAS inhibitors, SGLT2 inhibitors, and heavy weightlifting and high protein diet should be avoided. There is no evidence of use of immunosuppressive therapies in controlling the renal injury. And also, we need to address the issue of muscle dysmorphia because many of these patients will, even if they know that they have suffered renal injury, they will relapse because of this psychological issue of body dysmorphia. And there should be a structured endocrine regimen to support this androgen discontinuation in these patients. So the take-home messages are FSGS and end-stage renal disease they are caused by polypharmacy, and the insult is cumulative and it is compounded by multiple agents together. Biopsy is mandatory to detect the subclinical cases. Future research can involve administration of one supplement per group to be certain of its effect. Longer follow-up data is needed. So finally, we can say that anabolic steroids are definitely harmful. Creatine is generally safe, but some cases of AKI are reported. Vitamins should be used only within the recommended RDA limits. And proteins are not safe if you have a kidney disease, but if you have healthy kidneys, they can be considered to be safe. However, no one knows the upper limit and no longer follow data is available.
Thank you, Ravi. So we want to quickly highlight a problem now in society which actually has harmful effects in the kidney. So definitely a good fortune and privilege to have amongst us Professor R. Srivastava. I welcome him. He was a youngster. He was our former HOD in pediatrics and has done phenomenal work in establishing pediatric college in the country. He has written books. So we are very humbled and honored to have you here. And we like to have you and others.
Really is a pleasure to be here. After years and pushing back to these for all serum, CR and background. All this really we should learn everything every day. We don't say much in pediatrics, but this really is something we should know because it's such a common thing. It's so many places bodybuilding, gyms and all that. It must be dangerous. So it needs to be told to maybe even in the morning at gyms that thank you.
I just wanted to from there that in and one of the important causes of mortality is secret. So I'm sure there must be related to it. Yeah. So what can we say about will be normally from 1.3 grams to it's really of course but what we will see that it is someone who is what about this also AKI also they are not really all serious.
Whey protein.
Whey protein, I think
Lactoprotein, so it's a milk biscuit.
Because it is prescribed like Indian diet.
very good. So very costly.
Actually, with the fat of the society, unfortunately, this bodybuilding has now become an unregulated or a completely unregulated sector. So, as the first index case was taking, he was taking anabolic steroids, he was taking growth hormones, and he was taking 3.2 grams per kg of protein. So, that is a problem start. It's a completely unregulated sector. The end point is how you appear. That's all.
Because of pressure also.
Yeah, we have to
Okay, trainer as well as this. So both of them are trainers actually. They are all the professional trainers of the gym. So what they could be following, they could be teaching their students as well.
Regarding milk protein, I think there was one paper from the gastroenterologist. He had compared around 36 more famous brands. They had found that around 60% of the brands, the amount of protein what they put is not what is there. That is one, and nearly 14% had aflatoxins. It's not as what it seems. It's still at unlimited mark. Most of the products because
Can I have something quick show?
They take big protein.
We here take very protein supplements.
Yeah. They answer.
Practice one here.
Yeah.
We are not encouraging that. Proteins are probably babies are healthy.
Thank you very much.
Thank you very much.